Hello and welcome to PHM 6110. For today's class, we are going to discuss managed care. Because this is a broad and complex topic, I'm going to try as much as possible to keep it foundational for a whole bit. I'm going to cover a lot of grounds, but it's mainly going to be on the foundational level. We're not going to go in depth for most of the concepts, but I'm going to try to give you just enough sufficient information that you'll be able to understand what managed care is, how it operates, and some of the benefits and challenges that come with that. So, with that said, let's just get into it. There are three learning objectives for today's topic. The first is we're going to discuss managed care enrollment within within employment-based insurance, also Medicaid and Medicare. We're also going to examine some of the effects of managed care, specifically on patient outcome and provider service practices. And then finally, we're going to look at managed care in terms of its cost control objectives, in terms of, why hasn't it been able to achieve those. So let's start with the first learning objective. Very similar to the way I have done the previous topics, I'm going to focus one lecture video on one learning objective. So there's going to be three lecture videos in total for this topic, just in keeping with the way that I've done it for the previous modules. So, what is managed care? It is a system within the HSM, within the US healthcare system, with its primary goal being to reduce the cost of running the healthcare system and also to improve quality of healthcare delivery. And it does this by integrating four key functions. The first is that it looks at how hospitals are paid in terms of who is paying for it, in terms like employers, government, or individuals. It also looks at it from insurance perspective in terms of trying to spread financial risk across as large population as possible. And then it looks at the provision of healthcare services, trying to ensure that it's done at the best possible way in keeping with evidence-based practice, but also doing it in such a way that there is cost containment. And then finally, it also looks at how providers are paid or reimbursed for the services, and example would be fees and salaries and capitation. So why has what brought about this managed care? Where did that come from? Why was it necessary? So the first is that managed care is kind of done through managed care organizations, and one of the things that they're really into is controlling cost, and they do so by negotiating prices with healthcare providers. I'm going to talk about this a little bit more. And they try to ensure that care is provided only for the services that are necessary, which this is a measure against moral hazard. I'm also going to talk about moral hazard in a bit. And it really pushes for preventive care because it's lower in cost. So trying to get more people to do preventive care helps not just in health outcomes, but also in cost containment. Like we said, if there are more health preventive care, it kind of helps so that there's less chronic conditions and less expenses that comes with tertiary, secondary or tertiary care. So it also looks at reducing hospital stay, reducing hospital readmission, and it does this through care coordination. I'm also going to talk about care coordination in a bit more detail in a bit. So, having mentioned moral hazard, I just wanted to explain it a little bit for in case you are completely unfamiliar with it and you don't understand how this managed care plays a role in this. So, what managed care does essentially, or one of the things that it tries to achieve, is reducing moral hazard, and it does this by discouraging unnecessary healthcare utilization in terms of the services that people use. The idea of moral hazard is one that's kind of theorizes that when there are services for which people are not paying the full cost of it, they tend to overuse it because that service is available. They're not paying the full price of it, and therefore, because it's there, it's more or less like, okay, let's use it. For example, sometimes if there's a candy in front of you, or pastries in front of you, you eat it not because you're particularly hungry, but there's something nice in front of you, and you decide to kind of eat it. So moral hazard is that way, but with healthcare services. So this is a quote by Bill Clinton when he was pushing for the expansion of insurance care. You can read more about this. I included the link to it. So what Bill Clinton said was that many of us who have had fully paid healthcare plans have used the system whether we needed it or not, without thinking about the cost that is associated with it. Or, paraphrasing Bill Clinton. So that is essentially a way of understanding what moral hazard is. So managed care plans tries to reduce moral hazard by limiting the choices that patients have in terms of the services that they can receive or services they can use, as well as the healthcare provider that is providing the services that they're using. And it also does this by trying to promote efficiency. I'm going to explain in terms of promoting efficiency and also limiting patient choice in a bit, but I just wanted to introduce you guys to that concept. So, how does managed care address moral hazard? Like I said, limiting patient choices, promoting efficiency. I'm going to talk about it in a bit, but just kind of look at it from that lens. So, it does it through cost sharing mechanism, in terms of deductibles, co-pays, co-insurances, and stuff. It does this by trying to discourage patients from unnecessary doctor visits or treatments, because you're going to pay for every doctor's visit or every clinical visit. So you only pick the ones that you feel you have to use, rather than the one that feels nice. I don't know if that explains it, but more or less like, okay, like the example of the pastries in front of you and choosing not to eat it. Like if you're trying to lose weight, because the pastry in front of you or not, you'd be more circumspect in terms of, should I eat this or should I not. So it's very, very similar to how deductibles and co-pays work. So it also tries to do it from the provider end through utilization management, and it does this through prior authorization or step therapy, which the idea of it is that it only allows medically necessary services to be provided. I'm also going to talk about prior authorization in a bit, and also talk about step therapy. So if all of this would sound very new to you, don't worry about it. I'm going to explain what it means so that it all makes sense. So another thing that more managed care does in terms of addressing moral hazard is that it does it through gatekeeping systems, which is one of the ways of limiting patients' choices. An example would be how primary care providers in HMOs manage referral, and this way it kind of prevents overuse of specialist services. I'm also going to explain what HMOs are, and how this referral system kind of works within HMOs, just to let you guys know that we're going to talk about this, just in case these are all concepts that are 100% new to you. So I mentioned managed care organizations in the previous slides. Let me just quickly show, how we're trying to use managed care with managed care organizations being done through managed care. Managed care being implemented through managed care organizations. So managed care organizations are private or public entities. Sometimes they're public, but they're mostly private. So what these organizations do is that they try to manage the health services that are provided to people who are enrolled in them. So they are specifically concerned about people who enroll with them rather than just everybody. So their job is to manage healthcare, health delivery for those who are enrolled with them. So, and they have contracts with Medicaid, then Medicare through Medicaid Advantage, and also through employer-based insurance. And they do this as a way of providing care. So, in terms of cost containment or controlling costs by managed care organizations, is that they do this through negotiating provider contracts, through coordinating care, and also through implementing cost saving measures. So there are a couple of the types of managed care organizations which also corresponds to types of managed care plans, for which I'm going to talk about. So you have the HMOs, which is the health maintenance organizations. You how they limit patient choices is that it requires their enrollees to be in network care. So they kind of have to work with the providers that they have a signed contract for. And in order to see specialist care, in order to seek specialist care, it goes through a referral system with primary care physicians. So then you have the PPOs, which is a preferred provider organizations. This allows enrollees to, seek care for out of network care, but it does it at a higher cost in terms of premium. Your premium on the PPO is higher than your premium on the HMOs. And then you have the exclusive provider organizations, the EPOs. It's sort of similar to HMOs. The only difference is that there's no limitation in terms of referral. You're still able to use to seek specialist care without having to be referred by your primary care physician. And then you have the point of care service, which is a mixture of PPOs and HMOs. The difference is that you need primary care physicians to refer you to some services, not all services, to some services. So, like I said, the types of managed care corresponds to the type of managed care organizations corresponds to the managed care plans. So I'm going to still talk about all of this, PPOs, HMOs, but kind of explain it in detail in terms of what their services look like, right? So with the PPOs, patients who are enrolled into PPOs can visit any doctor, but if you're receiving care from a provider that is in network, your cost is lower, and you're likely going to cover more of the services than if you're receiving care from out of network. It's more flexible. However, your out-of-pocket payment is higher if you're receiving service from out-of-network care. Is the most common employee-based insurance model within the managed care model. Then you have the HMOs. Like I said, patients are kind of restricted within in-network providers, except for in cases of emergencies. The primary care physicians coordinate care and determine in terms of referring you to tertiary care with specialists. So the costs in terms of premium and also out-of-pocket payment is lower with HMOs and PPOs. However, it's much less flexible in terms of who you can choose to see. Then we have the high deductible health plans, which is often combined with health savings account. The premiums are lower. However, you have higher out-of-pocket payment. What happens is that with HDA, with high deductible health plans, you kind of have an amount of money that like the managed care organizations set out to say, after you spend so and so amount of money in terms of covering your care, they would then kick in and pay 100% of the cost. So I think sometimes you have individual be like $800, or you have $1,002. It all depends on the type of high deductible plan that you choose the higher the deductible plan, the lower your out of pocket payments, and the lower the in terms of how much what those out of pocket cost is before insurance kicks in. So it's often paired with the health savings account in the sense that you get to pay up those amounts of money from your health savings account instead of it coming out from, let's use for example, your credit card for it, which has you have some kind of interest on it, and also in terms of it, so it's tax free savings for medical expenses, so which is good in that sense. It's been gaining a lot of popularity among insurance-based health insurance. Southeastern uses this, for example. I am on one of those. And then you have the capitation model as one of the managed care model. But capitation is not from the consumer side of it, it's from the provider angle. So what capitation model is that it's a payment model where providers receive a fixed amount of money depending on how many patients that they see per month. So it's like per member per month. So this is a fixed amount of money that providers get from seeing X amount of patients. So it's not determined by what services that are provided, is by the patient that you see. So regardless of the services that you provide to a patient, if this is the number of times you see this patient in the month, this is the amount of money you will get paid for seeing the patient. So it covers all necessary services for those who are enrolled in their care. It does encourage cost-effective means and preventive care, like like I said, because it's very much patient per month, pay member per month. It's easier to kind of push for preventive care, so that you which helps avoid things escalating and getting worse. But like I said, the providers get a flat fee, so just coming and seeing this patient for preventive care that doesn't require as much services, you get the same amount of money. So it kind of encourages cost effectiveness in that sense. So the managed care system works in different ways. It does this through employment-based insurance. It also does it through Medicaid and does it through Medicare. So with Medicare is more Medicaid advantage, which I'll talk about. With the employer-based insurance, managed care covers almost 50%. Sorry, EBI, is one of the largest sources of insurance coverage in the US. Covers more than 50% of the population. With managed care, how it integrates with EBIs is mostly PPOs and HMOs, but more and more employers are opting for this high deductible plans and combining it with HSA. Like I said, Southeastern is one of those employers that does it in that way. So one of the challenges to the high deductible plans, like I mentioned, is that there is high out of pocket cost that goes with the employers. So this kind of deters employees from using the services, because they have to have this out of pocket payment in terms of co-payment for each hospital visit. And let's use, for example, if your out of pocket payment is going to be $3,000 before insurance fully kicks in, this may require you to do 10 visits in a year or 20 visits in a year. And so for each of your visits, you're paying this out of pocket payment. Some people may just decide it's not really worth it to go for this many services unless I absolutely have to, because with each visit, you're paying out of pocket. And sometimes that amount of money that you need to pay to get to the, your out of pocket may seem a bit too large. Therefore, you kind of discourages you from doing that. And then with Medicaid, how it works with managed care is that, over 70% of all Medicaid enrollees are actually done through managed care organizations, most of which are private organizations, like I mentioned. So, what happens with Medicaid is that the states have contracts with the managed care organizations, and it does this by, more or less like help us control our costs and help us, improve coordination with services. So there's been a growth in enrollments with the managed care organization that does it through Medicaid because ACA expanded Medicaid, so many more people became eligible for Medicaid who are now being, taken care of by managed care organizations. There are some challenges with this, one of which is that under Medicaid, managed care organizations does have provide limited network, and this is exasperated with rural areas where there are fewer providers that are signed into the network, so that this does provide some form of limitations, and it's made worse because most people under Medicaid cannot afford to go private, so they're kind of limited to what is available, which causes some challenges in terms of service utility. And in situations where there are funding shortages, managed care organizations don't do such a great job with social determinants of health, which then means that it even reduces the ability to address it, in situations where there are limited funding. So, like I mentioned, managed care organizations work with Medicaid through the Medicaid Advantage. So, and the organizations are done through private companies or private insurance companies. What managed care does with Medicaid insurance is that it gives them Part A, Part B, but it also gives Part C by offering extra benefits in terms of dental, vision, and wellness programs. More than 50% of all Medicare beneficiaries are in some form of managed care program or the other. So the reason why it's so popular with Medicare is because in terms of out-of-pocket payments is lower with managed care with Medicare Advantage than the traditional Medicare. They also added benefits, like I said, dental, vision that is available on Medicare Advantage that is not available for the traditional Medicare. And also, there's coordinated care through provider networks that makes it easier for services to be provided and everybody to keep track of what's happening with the health of the enrollees. However, there are challenges with delivering managed care services through Medicare Advantage. One of which is that there's limited access to out of network providers. Unlike Medicare, the traditional Medicare Advantage has restrictions that is similar to similar to HMOs. Like I said, you're kind of restricted within providers that are within network. Medicare Advantage has that limitation, and which makes it, like I said, rural areas having even more limitations than people living in urban areas because you have fewer providers participating in it. Also, referral services is very difficult under Medicare Advantage, thereby delaying complex conditions. And you remember, Medicare is usually for older people and people with disabilities. So you can imagine that they have very high need for complex, they have very high need for specialist services. So when specialist referral is difficult on the Medicaid Advantage, there are going to be many enrollees that are having challenges with utilization. So, and some of these challenges come with prior authorization and coverage and denial. So, most of the services under Medicare Advantage requires prior authorization or prior approval, which leads to a lot of delays and unfortunately a lot of denials. So, which means that a lot of the times enrollees tend to have to appeal the services that were deemed not medically not necessary in order to get those services. So a lot of it, you may have a provider saying this patient needs the service, and the managed care organization will look at it and say, "No, I don't think this is necessary." And then patients then have to appeal this decision in order to get these services covered. So while the premiums are lower under Medicare Advantage, the co-payments and deductibles are higher than traditional Medicare, which then means that people who are low income seniors they will kind of tend to struggle with the cost sharing element of it. And then when you add it to the part of being limited services, limited access is going to, make it even more difficult for them. And most of the plans under the Medicare Advantage usually targets higher individuals and try to avoid high risk enrollee. Even though with ACA and pre-existing conditions not being allowed for insurance companies to deny people buying into their plans, there's still some of these challenges that are still existing and have not been completely taken care of. So this is where we end for the first learning objective. Do come back for the second learning objective. See you in a bit.